So I think it's time. So we'd like to start our lecture series for today. And today we would discuss about FAPI PET imaging. And for the first session, Professor Yoon-Sang Lee will deliver us a lecture regarding some radiopharmaceutical aspects of FAPI PET imaging. So Professor Yoon-Sang Lee is right now a professor in Seoul National University Hospital, and he has, as I think, you all will be very familiar to Professor Dr. Yoon-Sang Lee, and he has dedicated mostly a lot in radiopharmaceutical, and he has published more than 100 articles regarding it. So please welcome Dr. Yoon-Sang Lee.
Okay, thank you very much for your introduction. Today, we will discuss about the FAPI imaging and therapeutic diagnostic agent. So actually, firstly, I heard this FAPI PET or FAPI therapeutics in the conference. I think that is somewhat I could not understand why that fibroblast is a common tissue or cell in our body. So that is a non-specific uptake will be high. So, but right after the I could see the image of the patient, then I was frightened that background signal to noise ratio is very high, and also standard uptake value is so high. So I think at that time, more than 2 years ago, at that time I decided to develop this compound after the searching the chemical structure of this fibroblast targeting fibroblast activation protein targeting radiopharmaceutical. Then I saw the only slight structure differences between all the radiopharmaceutical. So main skeleton is almost same structure, and then they change the linker and chelator for the diagnostic or therapeutic purpose. So I think almost same situation in the PSMA targeting radiopharmaceutical, because of that PSMA targeting moiety is a glutamic acid, urea, and lysine moiety, so-called GUL, and all the researchers, they changed the linker and chelating agent for a specific radionuclide. Then I think this FAPI imaging or therapeutic agent is almost same with the PSMA situation. At that time, we got the patent for a specific, just a simple molecule for a GUL and then NOTA complex, NOTA conjugate. And for this FAPI agent, we should select main skeleton. That is a I think there is a patent one, and also the linker already. You can find so many patents that is open for the public, and also before 1 year submission, after the submission of the patent, before 1 year we cannot see that patent context. So I think now opened disclosed patent is already more than 10 or 11 patents were there, are there. So I think more than 100 or even 200 patented structure will be there. So that's why I cannot jump into this project, but still we are focusing on this FAPI imaging or therapeutic agent now. So this is brand new Theranostics target, and also that diagnostic value is all very interesting and impressive. And I think in my talk I focused on how they can develop the FAPI imaging and therapeutic agent, and slightly I touched the chemical synthesis of FAPI imaging agent. And later on, Professor Min-Seok Seo will discuss the clinical impact of the FAPI imaging and therapeutic agent. Firstly, I think that is the first report for that fibroblast activation protein alpha related protein. They found one specific surface antigen, cell surface antigen, using the F19 antibody. That is the they used more than 19 astrocytoma cell lines, and from among 16 cell lines were positive for F19 antibody, and they found that to be a cell surface antigen molecular weight around 95,000. That is glycoprotein, and they thought that glial fibrillary acidic protein for in a human astrocytoma subset. And 4 years later, they finally found that that is the fibroblast activation protein, and this is the fibroblast activation, how they could find this protein. And another group, also they same US group, they in 1990 they found 170 kilodalton membrane-bound protease related with the invasiveness by the human malignant melanoma. So they used the melanoma cell line, and also they found that the membrane-bound protease that is related with the invasiveness. And then 4 years later, they also named that protein is a separase, so surface expressed protease. Protease means they can cut the protein into amino acids, so or the small pieces of peptide. So they call that is a separate. Finally, today, nowadays they found that the FAP and the separate the same protein for type 2 transmembrane same protease expressed almost all the pathological conditions, including fibrosis, arthritis, and cancer. And also almost 90% of epithelial neoplasm is overexpressed in the cancer-associated fibroblast. And what is the role of the FAP? You can see here in a cancer tissue, you can find the cancer-associated fibroblast on the that calf cell. You can find a FAP protease that can cut the that especially right next to the proline moiety, and then they cut any kinds of peptide or possessed of proline. And also you know that the FAP is overexpressed in the fibrosis, arthritis, atherosclerosis, and autoimmune disease, and metabolic disease and cancer. And as I mentioned, that in the cancer cell line, FAP is overexpressed in the breast, colorectal, pancreatic, and lung, brain, and intrahepatic bile duct, and ovarian cancers. So if you can make a FAP targeting radiopharmaceutical, then you can diagnose all kinds of these kinds of cancers. And what is the role of FAP? You can see here that is related with the cell proliferation and also cell invasion and angiogenesis and epithelial to mesenchymal transition and immunosuppression and drug resistance. So FAP can act, they can help the cancer growth or migration. And so if you prohibit that FAP protein, then you can expect that these kinds of things will decrease. So that's why people want to make a FAP inhibitor for cancer treatment. So they developed so many kinds of FAP inhibitor for that is related to antibody. So they can use they can be used immunotherapy and also small inhibitor and antibody cells and FAP dipeptidase activity. They block the FAP dipeptidase activity, and they already developed so many different kinds of small molecular antibody or peptide. So first, you can see here, FAP inhibitor was developed. That name is telabostat. They think that FAP mechanism is just like a cell cancer cell proliferation, or they can prohibit the STAT. So that compound name is telabostat and PT100, and that is a small molecule that firstly developed for inhibition of the FAP or the DPP4 dipeptidase inhibitor, and that is an orally available drug and also shows the slow growth of in a mouse model of fibrosarcoma, lymphoma, melanoma, and other kinds of cancer cell lines. And they underwent phase 2 clinical trial, but they said that some side effect and also will cause the some serious side effect from the FAP inhibitor. So I don't know that clinical trial was stopped or not, but I think till now we don't have any information of the phase 2 clinical trial result. So you can see here that is a very simple structure that contains the amide bond and then boronic acid. And another approach is the iodine 125 labeled almost the same structure with this TP100, and then they used for the atherosclerosis imaging, but result was not so good. And then Belgium group year of 2013, they developed the UANC 1110. That is the main skeleton for FAP inhibitor. Nowadays, you can see the almost all the gallium or rotation or F18 labeled FAP inhibitor is the they contains this main skeleton. Then they found that among all more than 30 inhibitor series, they found that this naptil contains fluorine conjugated one is that inhibitory concentration is less than 10 nanomolar concentration, and also that methoxyl group contains one is less than 10 nanomolar concentration. So FAP affinity is very high, higher than any other compound. So from this result, I think the Heidelberg group might move to focus on this compound. Then they elongate the linker for radio metal chelating agent, and then they contains this all the skeleton for FAP targeting. So after several years, Heidelberg group opened these frightened images in the SNMMI year of 2019. You can see the huge variety of all the cancer types. They said that 28 different cancer types can be detected by this new novel radio tracer. So these images are the image of the year in an SNMMI, and everyone focused on this compound, and also even open these images. We didn't know that FAP is the next target for Theranostics. So after that, everyone jumped into this FAP PET imaging or therapeutic into the clinical trials or clinical research, and they open the series of FAP agent. So you can compare that the earlier that Belgium compound, almost same structure with the Belgium compound, but this difluoride was attached into the some carbon skeleton, and maybe this difluoride can act as some controlling of the hydrogen bonding of the target site. So start from the FAPI4, number 4, to the FAPI55. Among these compound, they said that the FAPI46 will be the best candidate for the next clinical research. So they compared all the compound with for after the IV injection, and then they could find that tumor to blood ratio, and tumor to muscle ratio, and tumor to liver, and tumor to kidney ratio. And from these image-based comparison or biodistribution-based comparison, FAPI46 will be the best candidate for clinical research. And also they want to make a therapeutic agent, so they also labeled rotation 177 to that FAP 46 and all the compound, and then they found that the tumor to muscle or other organ uptake, then they found that normal organ uptake was relatively good in a FAPI 46. So they finally decide to the therapeutic decide to make a therapeutic radiopharmaceutical with the FAPI 46. So in same year, they opened how they could make these kinds of radiopharmaceutical in the start from the FAPI 1 to FAPI 46, and then now I think more than I think more than 10 hospital or institutes try to use this FAPI PET and therapeutics. So you can see here for FAPI 21, they contains a hydroxyl group, that is the ethyl group. Then maybe that stability will be poorer than this amino methyl group, because of that ethyl bond can cleave by the some kinds of hydrolase in the cells. So this amino methyl group can protect the or increase the stability of these compound. So finally, they FAPI 46 is the we can see the so many kinds of images, PET images, and then also therapeutic images in the clinics. So how can you make a FAPI 46? They said that that is very easy. You can purchase this FAPI 46 from the ABX, and I think in my thought that if we can use this precursor from the ABX, we have to get the permission from the Sophie Bioscience, but I think we have to confirm, but you can purchase from the ABX. And also another choice from the this FAPI 46 precursor can be made by the Chinese company. And if you search this FAPI 46 in the Google, then you can find that some company is in the list, and then simply you can ask to get this precursor. That precursor is not so expensive. I think 100 milligram is less than $200. And you can, this is the same structure with the earlier one, and then they use the 50 microgram and also more than 20 to several tens of millicurie of gallium-68, and they use the automatic synthesizer, and also they have some criteria for a QC pass test and acceptance criteria for a radiochemical purity more than 95%. But normally, we did the same experiment. We could get the more than 99% of radiochemical purity of the product. And also that all the QC criteria, you can do the almost same sequence. It is easy because of that that gallium labeling for a DOTA is I think that is very easy, and also you can put the just precursor into the automatic synthesizer is enough for synthesis. And another one is the F18 label FAPI 47. That is almost the same structure but without this difluoride, and also they possess that nota derivative that one acetic acid can bind to the another amino group. So only 5 chelatable agent for that is good for aluminum fluoride labeling. So you can get a fluoro-18 labeled FAPI compound. These compound also patented by the SOPI Bioscience, and also already we did this FAPI pad with the FAPI 47, and that it was permitted by the SOPI Bioscience, and that clinical trial was doing in our hospital. They said that more than 60 microgram of precursor used, and also that is the we can do the automatic synthesis and just to put this chelating agent and also this precursor, and then simply we mix the aluminum chloride and F18, then heat up to the 95 degrees Celsius, and after that we can purify by the simple C18 cartridge SPE method, and then finally we could get the more than 99% of the aluminum fluoride F18 labeled the FAPI 74. And now, as you can see here, a huge number of clinical trials already done. I think more than 2 or double or triple times will be done now are going on the clinical trials for even our hospital also are doing the F18 label, the FAPI 47. I think sooner or later, I ordered that FAPI 46 from the Chinese company. Then I think we can try for animal study first, and then later on we can do the clinical research. So this year they said that I think a FAPI PET can replace the FDG PET. So I think for this discussion, I think Professor Min-Seok Seo will guide that this is true or not. But I think they can, these two I think same patient with the different radio tracers they used, and I think they have some kinds of alternatives. So we can do the both images, and also we can increase the diagnostic value for a patient. So that will that is my opinion, but I don't know the exact consensus in the clinical stage. So finally, that definitely a good diagnostic target for cancer imaging. But I think still I have a doubt that that is a good therapeutic target. So I think after the several results of the rotation or actinin labeled FAPI agent, then we can compare or discuss if that is a good therapeutic target or not. And as you know that the Novartis buy the lutein dotatate and PSMA compound, and also they buy the this FAPI imaging and therapeutic agent this year, March. So I think Novartis own all the Theranostics in the world. So sooner or later, I think maybe competitors such as Lilly or Pfizer can jump into this competition. So this is the end of my presentation. I think if you have any question or comment, I'm happy to get. Thank you very much.
Thank you, Professor Yoon Sang-mi. Is there any questions or comments? So just a simple question. What do you think might be the that will be mostly used at the finally? Like there are many FAB agents. What do you think might be the most profoundly used?
Yeah, I understand because of that Heidelberg group already did I think more than 100 compounds. They compared it to more than 100 compounds, and then finally they decide that FAPI 46 even in vitro and also in vivo studies. So I think that kinds of strategy they learned from the PSMA stories, because of PSMA, for development of PSMA, they missed the patent application for PSMA 11, and also right after they opened that compound into the public, then every old scientist, radiochemist, jump into that development. So as you know, that so many different compounds was were developed by every other countries or researchers. Then Heidelberg group, they closely, tightly closed this idea up to year 2019, and also they tested all the chemicals for that FAPI agent. So, and then after that, I think they gave us that FAPI 46 or FAPI 74 is the best one. Then I think that will be the best choice for PET imaging or therapeutic radiopharmaceutical.
And might be, is there some attempts to label this with technetium for the PAP agent?
Yeah, it's possible. So, but I think as I know that they already patented by of the technetium or random labeling for that FAPI 46 or 74. That means that we can do for a research purpose, but we cannot get the patent for a technetium or other compound. So if you want to make a new FAPI imaging agent with the technetium 99M, and then we have to focus on another skeleton. I found that one research paper from Korean person in Gachon University, they found a different moiety for a FAPI skeleton. So I think that that will be the next choice for this new radiopharmaceutical development for FAP imaging. But I think that affinity is not so high, not so higher than FAPI 46.
So if we want to, like, for a research purpose, like clinical research purpose for technetium labeled FAPI, so like we have to contact Sophie or Novartis to use the research purpose, or
I think Novartis possessed that patent for marketing of that compound. So only for a research purpose we can do freely. So already that FAP inhibitor connect that conjugated with the azide group, then we can do the mechanism labeling or other copper 64 labeling. It's possible, yeah.
And I think just for last of mine, could you explain some more about why you are doubtful about as a therapeutic use of this FAP agent?
Because of, as I mentioned, that that FAP inhibitor, that not radio-labeled one, is also used for cancer treatment, and then 1 or 2 persons are dead after the taking this medicine. So that means that still we have a huge number of activated fibroblasts in the normal tissue. So we don't know, even this compound can penetrate the BBB. So I think that will be my concerns.
Yeah. Thank you very much. Would there be other questions or comments? Okay, if not, we can have some more discussions after the second part. So I think we can just move on to the second part without a break. Okay. Thank you again, Professor Yoon-Sang Lee. And next part, I will discuss some about some cases and clinical aspects of this FAPI PET imaging. So today, as will not discuss much about I will not discuss about the therapeutic usage of this FAPI agent, but more dedicated to as a pan-cancer imaging agent. So as a scene, the presentation will have a content like background and FAP as a target for various imaging. And the next 3, I will discuss about some recent studies in variable cancers and also some pitfalls which were recognized in recent studies. And also just we have done one case for this FAP imaging. So I would like to introduce this one case which was done in our hospital. So so the cancer-associated fibroblasts. So recently there has been some interest, increasing interest for not only for the malignant cells, but like non-malignant cells within the tumor microenvironment, which well are some like immune cells. So immunotherapy has recently been very recognized. And moreover, there is also a interest right now for this cancer-associated fibroblast, as this is a key component of the tumor stroma. And actually the tumor stroma account for up to 90% of the mass in cancers. So this cancer-associated fibroblast is getting more interest, whether it can be a target of therapy. And the origin of this cancer-associated fibroblast differ depending on the tumor histotype and where the tumor originated in the first place. But it can be separated into like whether it origins from the resident fibroblast, or it can be recruited from other sites, or it can differentiate it from the stem cells. However, it is known that most of these cancer-associated fibroblasts arise from the resident fibroblast, this resident normal fibroblast. And after it gets such a signal, it can, by the nearby cells, it can then differentiate into the activated cancer-associated fibroblast. And when activated, it has a diverse function, like it can do a matrix deposition, remodeling, and it has an extensive signaling interaction with the cancer cells and crosstalk. It also can crosstalk with the infiltrating immune cells. So as a result, it has a function to affect the tumor proliferation, tumor neoangiogenesis, and immunosuppression. So as you will recognize, because of these functions, many researchers thought this can be a target for tumor therapy. So they searched for what are some markers that are showing this, that are shown in this cancer-associated fibroblast. And this cough produces a number of proteins that are actually specific to the origin of the cells. However, there are no optimal specific protein for the cough. So right now they are using combination of these proteins, as you can see, as a marker to identify this cancer-associated fibroblast. And this FAP, the fibroblast activation protein, is one of them. And so these markers were recently investigated for the therapeutic target, as seen in this table. So there is, and also for this fibro activation protein, there is a ongoing clinical trial, as Professor Yoon-Sang Lee also mentioned. And the concept of this trial is that since this FAP is related with immunosuppressive of the tumor, when blocking this FAP, it can re-promote the T cell function. And by the tumor immunity, it can have a therapeutic effect. So there is an ongoing trial for this. So this fibroblast activation protein, there has been so many researchers focusing on this protein, and it is a transmembrane glycoprotein. It is expressed on the surface of the cough cancer-associated fibroblast. And the beauty is that this FAP is scarcely expressed in the normal mammalian tissues. However, on the other hand, the FAP expression is high in this activated fibroblast of various cancer. So, and the function, as I mentioned, is linked to an immunosuppressive of the tumor. So as a result, it is associated with the poor prognosis of the cancer patient. So again, because of such an interest, people also wanted to see how are these fibroblast activation protein expressed in the different tumors. So as you can see, the FAP is highly expressed in diverse tumors, and also interestingly, as highlighted here, that you can see that these tumors are like HCC, RCC, or cholangiocarcinomas or stomach cancers, has a relatively high expression of the FAP. And the interesting point is that these cancers which are known to have low glucose usage, which means that it has like low FDG avidity and limited for the FDG PET evaluation. So for nuclear medicine, it also has gained interest whether it can be an alternative target for cancer imaging and therapeutic usage. So as mentioned, as you have seen from Dr. Yoon-Sang Lee's lecture, diverse products and research are ongoing for this FAP as a target for imaging cancer. And moreover, as you have heard, that Novartis also have included this FAP in their pipeline for radioligand theranostics. So now we would like to more discuss about what is the beauty of this FAP for cancer imaging. So the first thing is that it can be used as a pan-cancer imaging agent. So this study, which was published in 2019 in JNM, it included 80 patients with 28 different kinds of tumor entities. And as you can see, the highest SUV, which was higher than 12, was found in sarcoma, esophageal cancers, breast cancers, and cholangiocarcinoma and lung cancers. And like HCC and colorectal cancer, head and neck or ovarian, pancreatic, and prostate cancer showed an intermediate uptake. The SUV max, average SUV max was in the range of 6 to 12 in these cancers. And the lowest FAPI expressing tumors were pheochromocytomas, renal cell carcinomas, and differentiated thyroid cancers and adenoid cystic carcinomas. However, the more importantly, as you can see here of the blood pool, because of this low background in the muscles and blood pool, the tumor to background contrast ratios were at least more than a 1-fold in the lowest group and like more than 3-fold in the intermediate and 6 times higher in the high intensity uptake group. So you can think that it can be used for like diverse cancers. And the nextly, as mentioned earlier, it has a low background in muscles and blood pool activity. Moreover, the important is because this FAP is scarcely expressed in mammalian healthy adult tissues, the normal organ uptake, as you can see, compared with the FDG PET is lower. And especially where FDG has high uptake, like in the brain or liver, this FAPI has a significantly lower uptake. And nextly, these FAP imaging agents have shown to be cleared rapidly after the injection. So as you can see, from this first time of the image, like from the first early 10 minutes, tumor can be well delineated compared to the background. So this FAP as a target for imaging cancer has many benefits because this FAP is expressed in the stroma of the tumor, not the cancer cell itself. And the stroma volume is normally larger than the cancer cells. So it might be more sensitive for small tumors. And because of the lower normal physiological uptake, it can have higher tumor to background ratios. And like, as you can see, it can be used in diverse cancers, even the cancers which have low FDG avidities. And because of the fast tracer kinetics, it is appropriate for imaging even less than 1 hour after injection. Like, so you can do an imaging like less than at like 10 minutes or 30 minutes. And because it is independent of such a blood sugar levels, the fasting is not required for this imaging. So because of these benefits, there are ongoing studies to find out what is the role of this FAP imaging for cancer evaluation. So many studies are done for the initial staging workup, tumor detection, and whether it can be used in the therapeutic response evaluation or like prognostic stratification. But for now, the recent studies are mostly evaluating this first part of whether it can be, it has an efficacy in tumor detection or differential diagnosis. And secondly, whether it can be used for the initial staging of the tumor. And I think later on, if these are more accumulated, there will be more studies revealing whether it has a prognostic effect or whether it can be used for a therapeutic response evaluation or for like surveillance purpose. So now I would like to share some recent studies in variable cancers. And this is a study regarding a hepatic malignancies. So total of 23 patients, which has a HCC and cholangiocarcinomas were included in this study. And as you can see in both tumors, the FAPI has a significantly higher uptake compared to the FDG. And regarding the sensitivity of the tumor detection, when compared with a MRI or contrast in NCT, it has a equivocal detection rate. However, as you can see, FDG has a quite significantly lower. And since this FAPI has a low liver uptake compared with FDG, the diagnosis of intrahepatic lesions are actually more, there are more differences. So like FAPI had a significantly higher intrahepatic lesion detection rate compared with the FDG PET. And moreover, what is known is that it not only the intrahepatic metastasis or the primary lesions, it also can detect in a high efficacy for the metastasis too. And this is a case of 45-year-old man with HCC who have done both FAPI and FDG PET for the initial imaging. And this study actually shown some interesting points for FAPI imaging in hepatic malignancies. What is that? Is that there was a significant change according to the differentiation of the tumors. So this was evaluated for the hepatocellular carcinoma patient. As you see that the poorly differentiated carcinoma had the highest uptake, and it has a significant difference compared to the well-differentiated. So although we also know that FDG has some difference according to the differentiation of the hepatocellular carcinoma, but in this study, it wasn't shown as a significant, but there was a profound difference in the FAPI. So it maybe can be used later on to show a differentiation, which might also be related with the prognosis of the tumor. The next important point that this study showed was that there is a difference in patient with or without the cirrhosis. Since the hepatocellular carcinomas are mostly accompanied with a liver cirrhosis, whether there is a background activity is important. But actually, this can be a drawback of this FAPI agent, since this FAPI has a significantly higher liver uptake in the cirrhosis when there is a liver cirrhosis. So it can be applied like whether to detect the liver cirrhosis. However, for the primary cancer detection, it may have a drawback because of the higher background uptake of the FAPI in cirrhotic liver cirrhosis patients. So these points should be actually considered when applying the FAPI PET for hepatic malignancy evaluation. And next study is about the studies regarding GI malignancies, including gastric duodenal cancers and the colorectal cancers. And the beauty, what they have suggested was that this FAPI can lead to a upstaging of clinical TNM staging compared with the FDG PET. And in this study, it led to like more than 20% of the patient were changed after doing the FAPI PET. And as similar to the hepatic malignancy, it also showed that FAPI PET has a higher SUV values compared with the FDG PET in every components like primary tumor, lymph nodes, and distant metastasis. And as you can see from the case of this 55-year-old man patient, which had done a FAPI and FDG PET for the initial staging workup, you can see that FDG PET had like minimal uptake, which was not discernible from the other like normal stomach walls, but there was a discernible uptake by the FAPI PET. And as from the pathology, it was found out as a gastric signet ring cell carcinoma, which is known to have low FDG avidity. And also, not only for the initial staging, it also can detect more lesions in a recurrent case. So this patient had a AGC, which was signet ring cell carcinoma, and had a recurrence. And as you can see that the FAPI can detect more lesions compared to the FDG PET. And there are also like, for the colorectal cancers, it can, in the initial assessment, it can detect more lesions, like especially because the colon cancer metastasized to the liver mostly, and because of this low liver uptake, it can detect these liver lesions better than the FDG PET. And there has been another study which used a PET-MR and samely compared the FAPI and FDG PET. And similar to the previous study, it has shown that for the detection of the primary lesion, FAPI PET, in all the cases, FAPI PET detected the primary lesion. However, in 82% was detected in FDG PET, and 18% of the cases were missed, and which actually included most cases were like signet ring cell carcinomas. And this study showed what are some relevant factors which are relevant to the high uptake in FAPI or FDG. And some relevant factors were known to be tumor size and depth of the invasions were related with the higher FAPI uptake. But however, although there is a significant difference in the like small tumor and bigger tumor, as this small tumors also have higher SUV values compared to the FDG. And since it has a low background, tumor to back, it has a low gastric wall uptake. It shows a higher sensitivity for the tumors, which is smaller than like 4 centimeters. And there has been also study regarding a pancreatic cancers. And as you can see that there was a markedly increased uptake in the pancreatic adenocarcinoma after 1 hour. And it was mostly seen in almost every cases. And as you can see, compared to the FDG PET, in the pancreatic cancer, it can detect more lesions of the metastasis. And so because of these results, what this study showed for the efficacy was that this FAPI PET led to a change in the staging, and like more than 50 cases led to a upstaging, which will change the therapeutic or management planning for the patients. And also there was some important points recognized from this study that there is a difference compared to the pancreatitis and the tumor. Since a patient with the pancreatic cancer often have a combined chronic pancreatitis, so it is important whether there is a difference in the uptake of FAPI in tumor and pancreatitis. However, there is a difference, but there are also some significant parts that are overlapping. So also the authors pointed out that in some case, it might be hard to delineate whether it is a pancreatitis or a tumor in such a case. However, what they have shown was that when they do a kinetic study, there are differences between this tumor and pancreatitis. So for example, like pancreatitis, but this was done in only 2 patients, so they haven't shown a statistical result, but there was some tendency of decreasing SUV values for pancreatitis. However, it was increased in the tumors, and what they used for the imaging was FAPI 4/6 for this patient. And the next part is whether it can be used for the head and neck cancer. And in this study, 15 patients were enrolled, and both FAPI and FDG PET had a 100% detection rate of the primary tumor. And actually for the SUV value, as you can see, were not significantly related with the FDG. So there was no significant relationship with the FDG uptake and the FAPI uptake. And also the average SUV max in the primary tumor was slightly lower than the FDG, but like without a significant difference. However, the importance of this FAPI PET compared to the FDG was that it can well delineate a cancer in the skull base or if there is an intracranial invasion, because FDG shows high FDG in high uptake in the brain. Some lesions in the skull base or in the intracranial invasion might be hard for the delineations. But some points should have been pointed out that this FAPI PET has some limited efficacy for the diagnosis for detecting the lymph node metastasis compared to the FDG PET. So as you can see, in most cases, the FAPI PET had a downstaging of the lymph node metastasis compared to the FDG PET. So it ended up like downstaging 3 cases. However, it has some also a advantage against FDG for detecting a distant metastasis, which end up doing a upstaging for these patients. So still there seem to be some limits that it can detect a primary cancer well, like especially for skull base and intracranial invasion. However, it might be limited for evaluation of the nodal staging. So these are some summary of what I have covered previously. So yeah, so for the hepatic malignancy, it has a high detection rate compared to the FDG, but you should check about the liver cirrhosis. And so in the liver cirrhosis, the background liver activity can be high. And also the important point was that there is a relevance according to the tumor differentiation. And for the GI malignancy, it also showed that it has an efficacy compared with the FDG PET, and that the size and depth of invasion is important and relevant to the uptake of this FAPI. And for the pancreas, there was the efficacy showed that compared to other imaging agent, it ended up by doing a upstaging more than 50% of cases, it had a upstaging. And however, there are some concerns about the combined pancreatitis. So, and the authors suggest that kinetic study might give some clues to differentiate pancreatitis with the tumor. And for the head and neck cancer, it has a improved delineation of skull-based invasion and intracranial invasion. However, compared to the FDG PET, it had still some questionable detection for the head and lymph node nodal metastasis. And there are also ongoing studies regarding sarcoma and gynecological cancers. So in diverse cancers, these results will come out and show whether the FAP imaging is applicable. So we have seen some recent studies. So now I'd like to discuss about some pitfalls which were recognized in recent studies. And as you can see, it can be like, because this FAPI is the activated this fibroblast can happen not only in the tumor, but also in like tissue repairing and also inflammations. So it can actually shown in such an inflammatory conditions, or whether there is a tissue regeneration, such as like uterus, like in the as for the menopausal cycles, menstrual cycles. So it can be like seen in degenerative bone lesions, and also it can be seen in the muscles where there is like regeneration, or like also in like scarring and wound healings. And because it has both inflammations and also the regeneration of the tissue. And also for mammary gland and uterus. So it has shown quite a lot of false positive cases can be seen in this FAPI PET. And so for examples, like for degenerations, you can see like facet joints or in the TM joints. And also you can see like for the, if there is for the post-operation site, surgical site also have such a uptake because of the wound healing and the inflammations. And also there is a muscle uptake. And some other uptake can be seen in like benign tumorous conditions like elastofibromas, and also because of the tissue regeneration, it can be seen in the uterus. And interestingly, uterine uptake is seen quite frequently. Like in one paper have reported that in 66.7% of female patients have shown a activation FAPI uptake in the uterus. And what they have shown was it was inversely correlated. The uptake was inversely correlated with the age. And another study showed that it had a significant difference from the premenopausal and postmenopausal patient. So this uterus uptake will be more, it might be related with the menstrual cycle. So when evaluating such a gynecological malignancy, these menstrual cycles should also be concerned for such a patients. And also there has been some mammalian uptake, which might be similar to a might be a physiologic uptake. And as you can see, like in the inflammatory conditions, it can also see like in tuberculosis, pneumonias, and also like benign tumors as like hemangioma can show such a high FAPI uptake. And like old myocardial infarction can be seen. And there are also like some studies using this FAPI agent for evaluating myocarditis or such myocardial infarction, like for evaluation of prognosis. So as a pitfall for tumor imaging, there can be it can show a uptake in inflammatory conditions, and in the physiologic uptake can be seen where there are like tissue regenerations, and also benign tumors can show a diverse uptake of the FAPI. So although it is for the tumor evaluation, it has many benefits, still we need to know more about what kind of other uptake can be seen in such a in non-tumorous conditions, which might be some drawbacks of the FAPI imaging, FAPI for the cancer imaging. And for the lastly, I would like to share a case from Seoul National University. So this is case of 69-year-old male patient who had chief complaint of the abdominal pain. And from the physical examination, the patient showed a icteric sclera and yellowish skin. And the CA99 level was elevated in the initial evaluations. So from the CT and FDG PET imaging, it has shown that there is a tumorous lesion in the pancreas head. And so the patient, because might be due to the symptoms, have done firstly SABR, the radiation therapy to the pancreas, the head mass. However, after the radiation, there was no significant change in the CT imaging, which was done before and after the radiation. So this patient before was planned to undergo the surgical resection of this pancreatic head cancers. Before this surgical approach, the patient underwent a FAPI PET study. And this is the image from 60 minutes after injection. And this is from 2 hours after injection. And as you can see, there are some physiologic uptake in the pancreas, maybe. And there is some discernible high intense uptake in the pancreas head. And from the transverse image, what you can see is that there are very low background uptakes. However, there are some pitfalls, like in this degenerative change also shows a uptake along the joints. And however, if seen from the 60-minute image, you can see a very intense uptake in the pancreas head. And also this uptake actually, however, is more intense in the 60-minute, and the uptake was decreased in a 2-hour image. And also what you can see is that there is a uptake in the PTBD insertion site, which might be related with the inflammation or tissue regenerations. And there were some inflammation along the body to distal pancreas. So the SUV for the lesion was SUV max was 15.2, and at 2 hours it decreased actually for 13.2. So we have some, actually this patient undergone surgery last week, and the pathologic results are not are not yet available. But from the surgeons, what they found in the surgery field was that there was some pancreatitis in the pancreatic head areas where the patient had a radiation. So this we think that the uptake in the pancreas head can be some combination of the tumor uptake and some fibrotic and inflammatory change after the radiation therapies. Still, there seems to be a discernible uptake in the pancreas and the tumors. And so this is some comparison with the FDG. And in some part, it seems that the FAPI has a like more extent compared with the FDG. But however, it might be due to such a combined inflammations or fibrotic change. Okay, and yeah. And one more point for the case is that there are, like, not only for the chronic pancreatitis, but for the pancreas itself, it is also known that FAPI can have like SUV max of 6 or 7 in the normal pancreas. So it should be also considered for the evaluation of the pancreatic cancers. Okay, so for lastly, this FAPI PET can be useful in various cancers, and especially in cancer with less FDG avidity, and in tumors in organs with which has a high physiologic FDG uptake, like brain and liver. And however, it is expected that there are various types of such a pitfalls, which was not experienced in the FDG PET. So we need to be more careful of interpreting the FAPI PET, and we need to gather more experience for such a false positives and pitfalls for the FAPI PET imaging. Okay, I think this is the end of my presentation. If you have any questions or comments, just really give us some questions or comments.
I have one question. you show the pancreatic uptake that is related with the pancreatic tumor or just normal uptake?
So we believe that this body to distal part is has just a physiologic normal uptake of the FAPI in the pancreas. However, in the head area, we still are not 100% sure whether this is a combination of the inflammation and the tumor, or whether it is just a tumor uptake. Since we don't yet have the pathologic result, and that the surgeons have pointed out that there was some pancreatitis when they had done the resection of this head area, pancreas head area. And since there was some decrease in the SUE max at 60 minutes compared to the 2 hours, we think there might be some combined inflammation in this pancreatic head areas.
Okay, thank you.
Okay, would there be other questions or comments? I think you can freely write.
Doctor, so
Okay.
this is Hendra.
Oh.
I'm sorry, I cannot open my camera.
Oh, it's just, yes.
Yeah. From your presentation, there are some drawback or pitfalls. So, do you think FAPI will be can be used for therapy, considering the maybe many pitfalls or false positive?
For the therapeutic usage, still not. There are very limited, limited studies which have shown limited studies were done, but still, because we have such a because it is a concept of Theranostics, I think we can still detect the patient who might have a response, and in the same time a lower toxicity. So I think it still has a promise for a usage for the therapeutic also. And what I think also is when you see the images, it seems that there is really a low uptake in the normal organs, which might be also a promising point for the therapy. So although there are lack of evidence, I still think it can be a useful tool for the therapeutics. And one thing is, and also what I think is that because it is, there are agents that are targeting the tumor, the FAP itself, which are in clinical phase 1 and 2 trials, it can also be used for such a imaging tool before a therapy. And yeah, so that's what I think for as a therapeutic agent. But still, I think there are some more things should be proven. And just one more, I think one more concern might be that this is not a cancer cell targeting agent. So the lutetium or yttrium beta therapy might have effect, may have effect because of its range of energy deposition, but it might be questionable whether ARPA therapy might be effective in targeting this FAP, because it is not actually targeting the cancer cells, but the stroma of the tumor. So like it might be questionable for the alpha therapy, but still I think it might be useful for the beta particle-based therapies.
Okay, thank you very much, Dr. Su.
Thank you. Okay, would there be other? Okay, I think if there is no further questions or comments, I think it might be quite fast, but we can end up the session for today. So thank you very much for the participation, and I think we can meet you all next week. Thank you very much.
Thank you. Bye-bye.
Thank you very much, Dr. Professor Lee and Dr. Su.
Thank you.